Hello everyone, my name is Lindsay and I am the Client and Lab Services Manager at Examen. And it is my pleasure to welcome you to the 5th webinar in our 2022 Male Fertility Series. As some of you may know, the webinars take place on a monthly basis and we are joined by an expert in their field of fertility treatment or therapies. The event is free and open to everyone, and we have a wide range of participants joining, from academics, healthcare professionals, fertility wellness specialists, as well as many men, couples, or individuals on their own fertility journey. The views presented in these webinars are the views of our speakers and not necessarily of our company, Examen. You're all very welcome to join us today. Please let me introduce you to our speakers. This month, we're delighted to have joining us Dr. John Sullivan. Dr. Sullivan was born in Dublin and trained and graduated from the Royal College of Surgeons in Ireland in 2009. He subsequently undertook surgical house officer training in Dublin and was awarded membership of the college in 2011. After this, he travelled to the United States and completed a 2-year research fellowship in men's sexual health at Memorial Sloan Kettering Cancer Centre, at the time completing a research MD. Dr. Sullivan then remained in New York to complete his urological surgery training with the American Board of Urology certification. Last year, Dr. Sullivan spent a year with Drs. Larry Lipschultz and Mohit Khera in Baylor College of Medicine, Houston, as a fellow in male reproductive medicine and surgery. He since has moved home to Dublin and will commence a male infertility practice in the new year after recently being awarded the fellowship of the Royal College of Surgeons. Our chair, Professor Sheena Lewis, is the founder and CEO of the Examen and an honorary professor of Queen's University Belfast, where for the past 25 years she has dedicated her research into novel tests for male infertility. She is currently an executive member of the Association of Reproductive and Clinical Scientists and chair of its Scientific Advisory Committee. She has published over 100 full papers, as well as numerous book chapters and reviews. She has been past chair of the British Andrology Society, UK National Representative and chair of the Andrology Special Interest Group of the European Society of Human Reproduction and Embryology, an executive member of the British Fertility Society, and was a founder, member and vice chair of the Irish Fertility Society. Professor Lewis's research has led to the formation of the company Examen, where we market the Exact test, which is now the market leader for sperm DNA damage testing in UK and Ireland. Before I hand over to Professor Lewis, I will run through some housekeeping. We will start today's session with a welcome and introduction from Professor Lewis. Then at approximately 6:15 to 6:45, we will have our guest speaker presentation, followed by a Q&A session with our speaker and Professor Lewis. Please do pose questions throughout the talks using the Q&A panel, but not the chat function. You also have the opportunity to rate questions, and Professor Lewis will then chair the questions during the Q&A session. If you experience any technical difficulties, please use the chat function and we will do our best to help you. Attendees will be muted throughout and videos enabled for our speakers only. All the events in this series are recorded and made available on the events page of examenlab.com, following each session so you can watch each event you may have missed. Please allow us up to 24 hours for the recording to be available. 1 CPD point will be awarded for attendees for the 1-hour event, and a certificate will be circulated a few days after the event. At the end of the session, you will be invited to rate the event. Please do so, and we welcome any feedback on today's event, as well as suggestions for future sessions. So without further ado, I will now hand over to our chair, Professor Lewis, to start the session.
Good evening, everyone. It's an absolute pleasure to be back with you. Excuse me, we weren't here last month because we were all off at ESHRA in Milan, enjoying mosquito bites and a lot of really good science. But we're back tonight, and I hope the weather is as lovely wherever you are in the world as it is here in Ireland, because we're experiencing one of the warmest summers that I can recall. Tonight we have a really, really special topic to discuss, and one which is very close to my heart, and that is bringing men center stage. Now, some of you may wonder why we even need to do that. Well, we're talking about couples who have fertility problems. Surely it's 50-50. Surely the men get just as much input and time spent on them as the women. Alas, no, that is not the case. And John, our speaker this evening, is going to tell you a lot more about that in just a moment. The purpose of these webinars is to raise the awareness of male infertility, and just the very point that I've been making, to show that men are not being looked after properly. Very often they don't have the best clinical care that they could have. And we also want to provide men, the patients, the clients, with knowledge and should I explain to them what advanced testing that they can have. And our real purpose in our existence is to help more men become dads. We want to demonstrate that couple care improves live birth rates. You can't just forget half of the jigsaw and think you're going to have optimal success. We've got to look after the man just the way we look after the woman. We want to demonstrate by our research that optimizing sperm health improves fertility outcomes. We want to help men to understand that they can improve the quality of their sperm, sometimes with just minor lifestyle changes. And at the moment, some of them don't know this, and they don't know that they're actually in control of their own destiny in a way. And we have a really big aim, and that's to help 1 million men on their fertility journey. Now, the evidence base for our test has been expanding over 20-25 years, and we've done many research studies in this area. We've looked at some prescription drugs and infertility. We've looked at cannabis and cannabinoids as biomarkers of fertility. We've looked at pentoxifylline as a motility enhancer. We've looked at diabetes and how it affects it and impairs fertility. We've looked at the effects of vasectomy reversals, because it would surprise you how many men have a new partner and they would like to have their vasectomy reversed so that they can become a father for the second time. And we've looked into that as well. And then, of course, recently, the most important thing on our research schedule has been looking at men and miscarriage, because that is something which up until 2012, no one even realized that men had a very important effect on their partner having miscarriage. And finally, we've been looking at DNA damage and unexplained infertility, because up to 25% of couples are given a diagnosis of unexplained infertility. And over half of those couples have got DNA damage in the male partner's sperm. So we've got ongoing research. That's one of the things that really excites us as a company. These are the things that we're doing at the moment. I'll not take up any more of John's time by telling you too much about them just now. But if you go onto our website, you can find out more about what we're doing. Understanding our test is really important. And we have some really unique parameters in our test, in that we can tell you the average amount of damage across the whole sample. We can tell you how many good sperm a man has. We can tell you how many bad sperm a man has. And all of the results are generated to ISO 13485 certification standards. So it's a very high standard that the test is performed to every day of the week here in our labs. We're delighted to say that measuring sperm DNA damage is now included in national and international fertility guidelines from Europe, from America, both in current pregnancy loss and also in sexual and reproductive health. And it's really important that not just we, but learned societies are also stressing the importance of what we ought to be doing to investigate the male and working him up to the best way for him to become a dad. So in America, if you have had a failed fertility cycle or you have recurrent pregnancy losses, the male partner should be evaluated by a male reproductive expert. John's going to tell us about that tonight, because he is a male reproductive expert, and he's going to tell us about the consideration that ought to be given to sperm DNA fragmentation. And then the most exciting thing that happened last year was the WHO guide, the World Health Organization guide, chose to put and extend the examination into their manual, saying that sperm DNA fragmentation was a useful test in many circumstances. Now, I think Lindsay has already told you a little bit about John. He's just become a consultant in St. James's Hospital in Dublin. He has a terrific CV, would impress anyone. He's going to be setting up practice in Dublin as a consultant, taking private patients from next January. And we are so excited to be involved with the beginning of his career here in Ireland, because he's the first urologist in Ireland who's interested in examining everything from A to Z of male infertility. He wants to take the whole man, look at his sperm, look at the quality of his life, and he has been trained by a very famous person, Professor Dory Lamb, who spoke to us previously, so he knows exactly what needs to be done. Now, so often we have had to send our patients to other places. They've had to fly off for consultations, but from next year that won't happen. We're going to have our own very, very well-trained urologist on hand, and that's the most exciting thing that's happened for quite some time. So I am going to hand over now to John. He's going to talk about bringing men center stage, and then we'll have a time for questions. So thanks for listening to me.
Can you hear me okay, Sheena?
We can hear you and we can see your slides. Great.
Great. Well, listen, thank you so very much for such a warm welcome and an opportunity to speak with you all this evening. It's rather humbling to speak in conjunction and as a peer as such with Sheena, who has an amazing record and reputation in the men's health, infertility and scientific space. And indeed, in the lead up to this webinar this evening, and after looking at pretty much all the previous invitees and speakees over the last couple of years, it is for me, again, rather humbling. Folks like Chris Barrett, Jonathan Ramsey, Dory Lamb, who I'll mention in a few minutes, rather giants in our space, and to be allowed to speak along with them and to tell you a little bit about what I do and what I passionately feel about in terms of bringing men back really involved in the diagnostic process is a privilege. So I thank you for that. I will not bore you about too much about my history. Sheena has thankfully and been very complimentary, such that I am, as of actually today, an attending urologist at St. James's University Hospital in Dublin, requiring a few hoops to jump through regarding the measurement of training from the United States to Europe and to the UK, but finally there. So look forward to coming online in the new year and offering a service that I think is very extremely needed in our health system. I don't have any conflicts of interest or disclosures this evening. I would, however, particularly like to acknowledge and thank three people, all based in the United States, of which I had the privilege to spend some time with, train under and learn from. Firstly, on the far left of the screen, John Mulhall, who is an Irishman, and similarly like me went over to the United States approximately the same time, in his kind of mid-20s, to undertake some research and some surgical training, and has remained there. Luckily enough for me, 9 years ago, not far off to the day, I had knocked on his door to ask would he give me the opportunity to be his research fellow, and he kind of scratched his head for a few minutes and was wondering, you know, who's this guy off the boat. However, I think he felt a bit of empathy with me, and I remained with him for 2 years as a research fellow, and he has been to this very day a mentor, an influence for me. The gentleman in the middle, Larry Lipschultz, is less known, I think, on this side of the Atlantic, probably the most famous, if you can describe him as that, andrologist and infertility specialist in the United States, and runs the longest running fertility program in Baylor College of Medicine in Houston. And I got to spend a year with him as a fellow, clinical fellow, experiencing the life in Houston and learning from a gentleman who knows an awful lot. Finally, I'd like to mention Dory Lamb, who now these days is based in New York City in Weill Cornell Medical Center, and is the Dow Professor of Urology and, amongst other things, Director of the Center for Reproductive Genetics. I never directly worked with Dory, but she responded to some mails some years ago that I was being inquisitive about in terms of certain things that she's the expert in. And ever since, we've developed a relationship, and I'm very lucky and respectful for that, that she's continued to stay in touch with me and is an invaluable resource. In fact, I call Dory Lamb and Sheena my two urology mums, so to speak. So this evening, what I wanted to do is to give you just a little idea, and I'm sure many people on the call will know anyways, as to the current landscape of fertility within Ireland. The question as to why at all evaluate the male. Is it not all female related? Well, I'll put the argument through this talk that it certainly isn't. And then finally, just to round off and describe some challenges that I think we face in our space and the changes that need to be undertaken to achieve equality of care for men. So firstly, to describe, and there certainly probably is people on this call who have more experience in the female and reproductive endocrinology space in Ireland than I do, whose names I won't mention, but are good friends and colleagues. But suffice to say that we're behind quite some way in Ireland to date. We are, as you can see on the slide, the only state in Europe at the moment not to offer a public funded IVF service. And most recently, only at the turn of last year, in a European-wide analysis, we ranked 40 out of 43 nations for access to fertility treatment, with the likes of Armenia and I think Albania and possibly Poland was the other nation. But so we're way off the bar here, and publicly funded IVF assisted reproduction is still a ways off. There is intentions and plans to bring it mainstream, but it's still a whilst away off. And as such, it's a booming private industry. The REI clinics, and I had been talking to Sheen earlier on just about some of the slides, and she said to me, remind me again about REIs, who are they? Well, that's my American accent coming out, because the reproductive endocrinology and infertility specialists, or the REIs, are the equivalent in Ireland to the people that run the majority of the infertility clinics. So they're trained obstetrician and gynecologists, they're physicians by trade, and have a particular interest or subspecialty training in reproductive endocrinology. The names of the clinics you would all know, but the larger groups that most people go through, of which there is an increasing number, a guesstimate being 12 to 14 at the moment, getting more by the day in terms of size. It's a large business. There's many couples that are struggling with fertility. Almost 10,000 cycles in 2020, as per an Oireachtas report or a bill, and information and introduction to same. So there's a lot of work in this area, and as you can see by the numbers, the cost of these fertility treatment cycles is not insignificant. In fact, it's rather very significant for the couple that are going through it. If you go through an IVF cycle, you could be paying up to $6,500 for just the one cycle. If you decided to go a little bit further and try to understand whether your baby had any inherited genetic defects that would make them either incompatible clearly with long longevity, or with diseases that would affect them after birth, you're adding another $3,500 in. So all in all, per cycle, and I could be corrected by certain folks on the call, but you're talking give or take about 10 grand. So that's where I have a particularly burning interest within, that being that it is to date, as it is elsewhere in the United States and in the UK and probably most other developed societies now is that the female is taken care of a little bit better, in fact, a lot better than the male is. And I demonstrate this point by just putting a couple of searches up on screen. As of last week, I Googled male infertility Ireland, not female infertility, not infertility, but male infertility Ireland, and also the male infertility space in Belfast. And you can see to the left of your screen that the names that pop up are all female, well, at least reproductive endocrinology clinics. You know, to fault, they are. There's no men's health clinic there. On the right, thankfully, I can say that my friends and colleagues north of the border, including Examen Health, second to last, are attempting, and correctly so, with respect, trying to intervene and say, hey, it's not just the female that has the issue here, it's the man as well. But so that's the landscape we're in, is that it is all, you know, female oriented. This is a little slide that I made up in jest, and I hope none of my reproductive endocrinology and infertility colleagues will take too much offense to it. But the point I'm trying to drive home is that many of the female clinics are intent on pursuing assisted reproduction with their patients, and IVF, ICSI cycles are very lucrative. I'm not being cynical, I'm just telling it as I feel it, and honestly, and many of the males are being overseen, or at least not worked up properly. So the jest is that, you know, here's this reproductive endocrinologist pointing a gun at me and saying, you just give me 20 sperm, that's all I want for ICSI, and I let you away free. The issue is, or my concern, and I feel strongly about this, is that the man is not receiving optimal assessment and management. So there's some sperm being procured for assisted reproduction, but the man is being not treated appropriately. And there's data in the United States. We don't have data to this effect because we don't have as adequate or as up-to-date databases. But essentially in the States, Mike Eisenberg, almost 10 years ago now, I did a review and saw that not far off a quarter of men in infertile couples in the United States were not being evaluated. So there was a whole group of guys that weren't even receiving a basic assessment in the first instance. And further analysis would show that, of course, when a guy has an issue with semen parameters, reproductive health, it is a marker and a barometer for other underlying medical conditions. Finally, on the slide, it came to be aware that there was, again, quite a large proportion of men that weren't actually getting assessed at all before they went to assisted reproduction. To this point, I was Googling in research to this chat this evening as to referral patterns currently in the United States. No studies to same in our part of the world to date, but this was a study that was printed and reported in the Journal of Urology in February of this year. And they surveyed fertility clinics across the United States to see if there was mention in their websites as to the male issue and as to treatment for the male issue. It transpires that, yes, almost 3/4 of websites did mention that there's a male fertility component, but that only half or less than half of them discussed any treatment. So they're welcoming men in, into the fertility space, but not really, putting an argument to them for, reversible causes and treatment. I think Sheena might have mentioned earlier, but it's a well-known fact in the fertility community that almost half of the fertility issues are at least in some part male-related. Almost 25 to 30% are purely male factor. But when you add in a mixed factor, it's almost 50-50. So, again, we're a ways behind. So, why bother? Why bother working up the male? Well, I'll explain my reasoning in a few minutes, and here's here's Homer Simpson, and I'm quite surprised that he got a semen analysis done in the right. You wouldn't have thought he's that sort of guy, and indeed most guys aren't. But if they are evaluated, and if their semen analysis is suboptimal, well, that is quite clearly a barometer of the man's overall health. So it shouldn't be just put to one side and the discussion be, well, how much sperm do we need for this assisted reproduction cycle? It should be, okay, let's pay a bit more attention to this gentleman and his health issues. Indeed, the societies at both sides of the Atlantic, both the American Urology Association and the female equivalent of SAME, say that both partners should be evaluated at the same time. NICE in the UK say couples who experience problems in conceiving should be seen together. And the EAU go even slightly further to say that a comprehensive andrological examination is always indicated if the semen analysis is abnormal versus the reference range. So essentially, my argument or my reasoning is such that men are being detoured to the side, as I've said, and not really getting the proper care that they need. The kind of point of care within the United States and now within the Republic as well for infertility issues is either the general practitioner, the primary care physician, or the gynecologist. Once the patient has seen both, it is usually the case that they are bypassing a urologist or a male fertility specialist and being sent directly to an infertility clinic. So what's the role of the men's health doctor, the urologist, the surgeon, but also the andrologist or the men's health physician? Well, is it only to assist in sperm retrieval, get some tissue for ICSI and assisted reproduction, or is it to treat the affected male? Well, my argument would be, again, is that it's extremely important that the man is not left on the sideline here and that he is treated appropriately, worked up and diagnosed. So what I feel, and at least what I've been taught in my experience to date, mostly on the other side of the Atlantic, is that there is 4 main kind of pillars of why the male with suboptimal semen analysis should be treated. Firstly, the diagnosis of serious or life-threatening conditions, because as you'll see in a second, it's often the case that the marker of, or a marker of bad news and bad disease is a suboptimal semen analysis. Secondly, to identify and successfully treat reversible causes of fertility, to define untreatable causes of testicular failure, and then to assist in sperm procurement procedures to enable IVF ICSI to be undertaken. To the first point, there's been many studies to date that have shown that there's a clear link between men's semen quality, both motility and the more commonly used markers such as DNA fragmentation now, and eventually bad news and bad disease. And here, about 10 years ago, excuse me, in the Journal of Cancer, a study looking at men over a 12-year period showed that there was a marked increase in all forms of cancer in men that were azoospermic, or who had no sperm in their ejaculate. So there's a clear link. Mike Eisenberg, who is very prominent in the United States now as a men's health and fertility specialist, had looked at close to 10,000 men in California some years ago, and he had seen that there was an association between abnormal semen parameters and risk of comorbidities. You can see the list here, whether it be an endocrine apathy, a genitourinary condition, skin disease, high blood pressure, or heart disease. They were all statistically significantly associated with abnormal semen parameters. So never mind about general overall men's health, which I feel passionate about. More pertinently to the talk this evening is, well, what can we do to get men and women away from having to undertake very expensive cycles of reproductive fertility processes to have a baby. And this is a slide that Mark Goldstein, again, another giant of male infertility in the United States, puts up every so often in his presentations, and I'm copying it from him this evening, where he shows on the right-hand side of the screen, you're paying your 10, 12, 15 or more grand for your IVF, assisted reproduction. And if you can push the bar, or at least push the angle to the other side of the screen, that being sex, which is essentially free, that is a natural conception, and that makes more sense to anyone, most importantly, the couple that are undertaking the diagnostic process. So it's to shift the bar and shift the, upgrade the male fertility status closer to normospermia, or normal sperm count. So what do we do? What do I do? I'm a men's health expert who doesn't really do a huge amount of this at the present due to the fact that, and constraints to licensing, but will again do quite soon, and would hope that we'll see many men with the male factor issue, that almost half of fertility couples that are struggling with male factor infertility. And the cornerstone, which has always been the cornerstone to date, albeit thankfully changing with some more exciting tests like Sheena had mentioned with her DNA frag test, is a good history, a good physical examination, and the semen analysis. The man, I can only guess, but because I have not been sitting in the room in the female fertility clinics, but is probably not asked all the questions that he should be asked, that a men's health or infertility specialist would. That being issues with erections, sexual dysfunctions, abuse of testosterone, even things like sitting in a hot tub or a sauna or a steam room. When you, on a regular basis, if you increase your temperature in the scrotum, is going to have an issue with fertility parameters. Actually examining the man, putting a hand on the abdomen and the scrotum, being able to palpate, visualize and palpate a varicocele, which is a dilated plexus of veins within the scrotum, the presence or absence of the tube that connects the testes to the back of the prostate, the vas deferens, and other obvious examination abnormalities that would be apparent to me or one of the folks that was trained like me, and maybe not to a female specialist. Indeed, the varicocele, which I've highlighted on the left, which again is a dilated plexus of veins within the scrotum, is extremely common within the general population, almost 15%. In infertile males, twice that. And indeed, on multiple analyses, it's been shown that previously, or men that have previously fathered children that have now developed a subsequent infertility issue, that almost 3/4 of them are experiencing a varicocele. So what can I do? What can we do, to bring men center stage in terms of the treatment algorithm? Well, it's to focus more on the man, and both medically and surgically. Medically, I mean the ability for us to change their lifestyle, change the certain things that they might not think are doing any issues to them or having any effect at all, but in reality are having a lot of effect. Drink, alcohol, smoking, etc., etc. Getting men fitter, seeing a difference in their fertility parameters after basic lifestyle adaptations. The endocrinology experts would be, and of course be well aware of this, not as much the men's health people, but and certainly I would have thought slightly less in terms of the female specialists, but manipulating the hormonal axis, changing or diagnosing hypothalamic, pituitary, gonadal endocrinology issues that can be treated, reversed, or if needs be, supplemented with exogenous hormonal therapy. Managing testosterone abuse, that's a big thing. It's not for tonight's talk, but in briefly to suggest, or at least to make you aware, that there's many men out there who might be struggling with their girlfriend to have a baby, and they think, I'll just Google what might be the issue, and the issue would be, or at least they might find incorrectly, is that their testosterone is low enough. So what does Joe Bloggs do? He goes and he finds a way of getting some testosterone that he can inject or he can take as a pill. And that is the exactly thing that he should not be doing, because it almost over a period of weeks makes him completely asospermic, or not having any sperm in his ejaculate. So there's the ignorance and there's a lot of abuse to that going on. And then the not unexistent reality of other things like not being able to penetrate your partner with an erection sufficient to result in an orgasm. Having a process of retrograde ejaculation, such that your sperm are, for the most part, being returned back into your bladder at time of orgasm, and not being pushed antegrade, in the normal fashion. And there's medications and treatments that we can help with that. In terms of the surgical side of things, men may not be getting diagnosed appropriately with certain obstructive problems. So one particular issue, which is very common in Ireland, cystic fibrosis. In fact, we have the highest rate of carriers on the planet. But these men they do not have a vas deferens, so they can't actually transmit sperm from the testes to the back of the prostate. And obviously these men are, for the most part, getting picked up. But there's other types of vasoagenesis that might not be getting picked up by the reproductive specialist, or an obstructive problem at the back of the prostate, where a simple transrectal ultrasound will be able to show why the sperm are blocked. In terms of procedures to improve sperm health or sperm production, a varicocele, I'll talk to you about in a second, is a very reversible procedure, or a procedure which can result in reversible sperm parameters and DNA fragmentation. And then, not within the realm of this talk, but reconstructive options, joining back a vas deferens after it's been separated. Guys that get the SNP when they decide they don't want to have any other babies, almost 500,000 a year in the United States. Numbers over there show that about 8% of them decided they wanted reversed at some point, whether unfortunately they get divorced, whether their spouse might pass away, whether they, for whatever reason, decided that they wanted again. And then finally, under the microscope, trying to find the most healthy sperm possible for assisted reproduction. So, focusing on the varicocele, this dilated plexus of veins within the scrotum, is there a place for repair of this in the assisted reproduction era? It might be argued, and certainly that it's not completely one way or the other, and I suppose it depends who you talk to and their opinion. But I feel anyway that the slight leaning at the moment is that this does make a difference. And there's so many papers I could go through tonight, but one particular one, by Matt Coward, the crew in North Carolina in Chapel Hill, had done a systematic review and a meta-analysis, and they'd shown that that for, amongst other things, pregnancy rates, the successful assisted reproduction, the numbers were improved with a varicocelectomy. So yes, I think that's still part of the algorithm. And again, it's not just a numbers game. On the left here, you'll see that the impact that repairing a varicocele has on the various semen parameters, or sperm parameters, that are most commonly commented upon. However, less likely is known about how a varicocelectomy decreases DNA fragmentation on the right, the very tests that Sheena and Examen Health perform and analyze for us. And there has been significant studies to show that if you fix a varicocele, your DNA fragmentation rate or your percentage of abnormal sperm will improve. And I think that there's something in this. As such, you know, I mentioned current guidelines, and I'm close towards the end here, but the Europeans and the Americans still consider that a varicocele repair should only be undertaken if there is a clinical, palpable varicocele with an abnormal semen analysis. They do, however, the Europeans say that you may consider in men with a raised DNA fragmentation abnormality and otherwise unexplained fertility that you should undertake this repair. The Americans are less progressive, but I genuinely do feel that DNA fragmentation is a marker of sperm health. It's a metric of the overall health of the sperm. And if it's been shown that by a simple operation that you can improve this DNA health, then I think that the chances of, never mind normal or natural pregnancy, but you know, if needed, assisted reproduction success rates will improve. And to that point, the current guidelines show that in Europe, a DNA fragmentation test is really, to date, only indicated for recurrent pregnancy loss for men with unexplained fertility. In America, they don't even recommend it as the initial evaluation, but yes, if recurrent pregnancy loss. So, you know, I'm certainly a person who believes in this sperm health investigations, and I think it's only a matter of time that it'll become essentially part of the initial workup. I feel strongly about that. So to wrap up, I'm super duper warm here now. I should probably put on my fan, but if I put on my fan, you mightn't hear me. So I'll turn on the fan afterwards. But to talk to you about what I think needs to change for more of an equality of care. There's four main, in my view, main areas. One is to educate both patients and doctors as to the fact that the male has a significant involvement in assisted reproduction, in fertility, in general men's health, and it is not adequately or equally recognized to date. So get the word out, get GPs and patient education evenings like Examen Health we're undertaking tonight, you know, out there, online social media presences, and to remove the stigma, such that a man does not feel that he's in some way suboptimal or faulty, that he can't achieve a pregnancy, a natural pregnancy with his wife. To that point, and we're a little bit away from it in Ireland to date, but Paul Turek, you see the Turek Clinic in the top left, but he was one of Larry Lipschultz's original fellows, and based in Los Angeles. He has a couple of clinics, and this is very much an American thing, but you know, it was on Good Morning America a couple of years ago. I saw it, and I started to giggle. But you can go with your bro or your friend, your mate, to go get both of your vasectomies together. And he does a nice little day for you. You know, there's a party pack. You can have your glass of champagne before. You can have, you know, it's done under local anesthetic, and then you get your champers and your pizza afterwards. And you know, so that's probably a little bit left field for Dublin City at the moment, or Belfast, but you get the point that we need to get, you know, men's health more out there. The second is to train people that have an interest in this. And I know this because I've spent time in both training systems in the UK and in Ireland and across the water in the United States. And I see from colleagues of mine the access to infertility training in the United States is at a different level. And I'm afraid we can't compare. And this study some years ago was just kind of pooling what urology trainees thought of infertility. Almost a third of them said that they had no access at all to any infertility training. So just didn't even know about it. I mean, they had to know about it for their exams, but they didn't, you know, sit in front of a surgeon who was trained in it. And of the remaining 27%, of the remainder, only 27% rated that their training was adequate. So huge gap. We're not training enough people that have an interest in this. and maybe we should be sending them, if we can't train them at home, sending them further afar. Thirdly, to that roughly same point, dedicating clinics in their entirety to men's health. And I'm not talking just about sperm parameters, semen health, reproductive health, which is obviously extremely and crucially important, but the totality of the male, whether it be a cardiology or an endocrinologist or a general men's metabolic health specialist who, you know, in an environment with other like-minded individuals, really, you know, push the bar for men's health. Finally, what I wanted to say is that, of course, the reproductive endocrinology and infertility clinics and our colleagues, of which many are very good friends of mine, are not people that we should be distancing ourselves from, or people that we should be vying for patients instead of going straight to them. That there should be an absolute you know, cycle of care, such that the men's health specialist refers and gets referred GP clinics and fertility clinics, and we all work symbiotically to improve not just the man's health, but obviously the health of the couple. So that's it, and I thank you so much. I might turn on my fan here and then pass it back to Sheena. I think there might be some questions.
Yeah, that's great. Could you turn off your presentation as well,
Yeah.
and then we'll get bigger views. Fantastic. Thank you so much, John. That was really, really informative. You gave us a lot to think about. I take your point entirely about men's health. You know, we hear about well women's clinics and, you know, the worried well, which is usually 99% women. But how do we get men to become interested in their own health? Because I've heard statistics that, you know, men only go to see the doctor when they're really, really ill, and they cost the NHS a vast amount of money because they're already, you know, seriously ill by the time they get there. And there's very, very little in the way of preventative illness in terms of. So what would your advice be as a man to men? What would you say to them they ought to be doing?
Well, I mean, oftentimes doctors are probably not the best people to give advice in many ways, because there's not. I probably enjoy the odd pint of Heineken a bit too much myself, although albeit not a smoker and whatnot. But you know, in terms of, I think it's about not being, you know, patronizing to men, not telling them about how many faults that they have and how many things are wrong, but that just really trying to, you know, to educate, and whether that's me meeting friends, you know, in a social environment, or whether it's me on an evening like this, or in the paper, in the news, you know, just really giving them some figures. I mean, men aren't stupid. They might be a little bit more slightly reckless, or at least traditionally risk averse in terms of health. But I mean, I think that there's a new, you know, attitude to kind of looking after themselves. I know my lovely father and friends of his probably wouldn't be the first men to run down to their GP with an issue, but I do think that that's changing. So we just need to continue to you know, to educate.
Yeah, absolutely, absolutely. I take your point as well about the stigma, and I think that is changing a little bit. You know, there've been a number of comedians now who started to talk about fertility issues, and I think those things are really important to get men to realize that having a problem with fertility is not an emasculating thing. It's not something which makes him in any way inferior, or a poor husband or poor lover, or whatever it may be that he feels. So I think that's very important, and I do think that's changing, particularly with the chat rooms. There are quite a lot of men's chat rooms now where men do actually do the bro thing and talk to each other and, you know, have conversations. So that's all really good. We have a couple of questions here. Let me just see. Oh, well, one of them says, great talk. Thank you very much. I would totally agree with that. Then the next one is, I'm a fertility reflexologist based in Northern Ireland. I have a couple who have a varicocele. He has seen a urologist, but he won't go for the repair procedure. So what would you do in that scenario?
Well, I mean, you know, without finding out from him himself or his partner, you know, a little bit more as to why he wouldn't engage in it. I mean, I'd like to have a conversation with him myself, and maybe, you know, tell him or educate them to the success of the procedure in terms of improving his semen parameters. I mean, there must be, is there not, so very many men out there that decide that they probably go to a fertility doctor with their partner, kind of dragged along. So they're told, well, you can have 2 inguinal groin incisions and we'll play with your spermatic cord for a few hours, or you can just take a tiny little needle biopsy from your testicle, and it's happy days, happy Christmas, and then we'll just use that tissue for for artificial insemination. So again, I come back, without the broken record, to come back to educating, adequately informing guys as to the benefits of it. So and there's many ways to repair varicocele. I mean, it depends who you talk to. You're talking to a surgeon or a urologist this evening who would argue that the best form of repair is an inguinal, microscopic inguinal repair, but there's other ways to do this.
That was my next question to you, John. I was going to ask you about that because I know embolization has become very trendy now. It takes less time for the man to be back on his feet and back to work. But as a surgeon, you're saying that that's not as good as a varicocelectomy. Well,
I mean, of course, if there was an interventional radiologist that had a subspecialty in embolizing, scrotal veins, we might have a good argument online here this evening as to the benefits and drawbacks of each. But there has been analysis done looking at failure rates, recurrent hydroceles, and successful. Actual successful, improvement in parameters and assisted reproduction, and the microscopic varicocele, albeit by not a country mile, but it certainly is significantly better. But I mean, I wouldn't personally, if someone said to me, "You're not going near me with a knife ever. Is there any way else that this can be done?" I'd have no issues for 1 second to send them to a colleague of mine to get embolized.
Okay. Well, another question is about this. How long after a varicocele operation would you think it would take for the sperm parameters to improve?
Yeah, I mean, it's going to be at least 70 odd days, 74, 75 before you see any difference here. So and that's a very good question. It's an important point, is that if you're really, under the clock here, and if you're in a relationship with a female who is over 35, over 36, getting on there, that really, time is of the essence, and waiting for 3-4 months for the effects of a full cycle of spermatogenesis to be reflected after repair maybe is not the best thing. Now, if you've got a bit of time to spare, and it really only is 3 or 4 months, then it's still an important thing to consider.
Here's another issue. I'm not sure what it's like in Ireland, but certainly in the UK, the only reason a man can get a varicocele repair on the NHS is if he's in pain, not because it might help his fertility. So how are we going to change these things? Who is it that you need to influence to make these pathways available to people?
Yeah, well, I mean, this is it's a really important point, that the vast majority, if not all, of male fertility care, and indeed female, in Ireland, is in the Republic at the moment, is private, and it's not far off, if not exactly the same, in the UK and up north. Whether it is a change or a twist towards, or a pivot towards a private care in this space. I know that isn't the female space, but for me, I can't take someone too easily to get a varicocele repair in the public system at the moment. And I don't think it ain't gonna happen anytime soon, I'm afraid, in the public system. So to answer your question, in the short, medium term, it's probably investment, from large centres internationally to decide to buy into a men's health centre in Belfast or in the Republic, and we can start going to work on these guys.
Yeah, I think one of the big factors is the association between poor semen parameters and later onset disease. I think that's a really, really big one. I know this guy, Mike Eisenberg, has been talking about this for a long time. But if the health system was to realise that so many of these people who are being picked out now with poor semen are the people who are going to have, you know, cardiovascular problems, who are going to have comorbidities, who are going to have mortality, and how much is it going to cost in the future?
Yeah.
You know, there's a very big argument for being cost effective to resolve the issues now.
Absolutely, I could not agree with you any more than well, what you've said. You know, it's the frustration that we face both north and south of the border and across in the UK, that for all that we think our health systems are great, and in many aspects they are, we are so far removed in so many different areas, and this is one. And the reality is that, I mean, if I can't get, or my colleagues who are cancer doctors can't get a person with bladder cancer in, or a person with, you know, prostate cancer to operate on them, you know, very easily in the public system in Ireland, you know, it's going to be a while before the guy with, you know, early onset diabetes or minimally impaired, you know, semen analysis is going to, you know, skip the queue to the top.
Yeah, I know. There are quite a number of questions here. Are people who would love to refer patients to you. So John, roll on, you know, roll on. January, I don't think you're going to have any difficulty in setting up your practice. I just wanted to say or to ask you one further question. I mean, I know we've talked about guidelines, and I know we talked about NICE, which is the National Institute for Clinical Excellence in the UK. And I wonder, you know, as a doctor, how many doctors really do go by recommendations? Because they seem to be, you know, the gold standard. But I wonder, you know, in everyday practice, is life not too difficult to actually do these things?
Yeah. Well, I mean, as you say, in the end of the day, they are guidelines, and they're there to help us, you know, make a clinical decision. But that, and it probably comes down to experience, I would have thought, in many aspects of that question. That, you know, the younger you are, albeit some grey hairs in this hair, but the younger you've been in clinical practice for, the probably you lean on the guidelines, because you've just done the exam, or that's the kind of that's the kick to touch, that's a safety. Whereas the more experience you get, and in
less likely.
Guys like Chris Barrett or John Ramsey or whoever else, you know, would might be a little bit, you know, more risk or less risk averse. Let's put it that way.
Yeah, sure. I know. But I think one of the things is lack of resource. You know, there's been a new initiative in Europe which is called the Male Health Initiative, and it's set up by the two Chris's, Chris Barrett and Chris de Jong, who's from, you know, across the pond, and they would very much like to do things to show how male health is going to be you know, a huge public health, you know, issue in the future if we don't look after men in their youth. But even the European Society, you know, puts piddling amounts of money into this, you know, like 20 grand, 30 grand. You can't do any proper studies. And even, you know, even learned societies don't really put money in to support some of these initiatives. I find that terribly sad.
Well, I mean, you've been at this for, you know, you're about as knowledgeable in this subject as anyone in the world or in Europe. But I mean, it's not going to be easy. I don't know what you've got if you got the answer or thoughts about it, but we have a fight in our hands. But you know, it's always good to have a fight in your hands, and if you're doing the right thing, it's about getting out there and getting it known.
Yeah, oh, I agree with you entirely. Well, I don't think we've got any more questions, John, so we're going to let you go and enjoy the rest of your evening. I can't thank you enough for being with us tonight. You've given us loads of information. There are a number of questions here about, as I say, people who would like to get in touch with you, and we can answer those offline. The next evening we have, what's the next evening? Oh yes, I know what it is. It's Vivian Hall, and it's next month, and she's going to be talking. She is a clinician who's in London, and she's going to be talking to us. You can find all the details on our website again. It's the first Tuesday of September, and we'll see all of you then, I hope. And thank you very much for your attendance tonight. And we really do appreciate everybody taking time to talk about men and bringing them center stage. So thanks and goodbye for now.
Thank you so much, Sheena.